my talk in CSI was on heart failure in COVID-19 and post-COVID scenarios. I will first talk about COVID-19 in patients with a pre-existing history of heart failure. So first we will see whether there is an increased susceptibility to COVID-19, but actually there is no difference in susceptibility. The susceptibility is same as any other person. But those patients who have a history of heart failure have a higher mortality. But other heart diseases, when they are adjusted for other risk factors, there is no increase in mortality. So heart failure is the only condition where associated with a higher mortality. And heart failure with reduced ejection fraction has a higher mortality compared to mid-range or preserved ejection fraction. The mortality in patients with a history of heart failure due to COVID-19 is higher than patients without a history of heart failure. So how to manage these patients? So with a history of heart failure and afflicted with COVID-19, continue disease modifying drugs, including ACE inhibitors. Drugs may be modified according to fluid status and blood pressure. Closer follow-up of an LV function and look out for arrhythmias should be done. And vaccines should be given after 3 months of recovery if they are not vaccinated. Now we will go on to COVID-19 related heart failure itself. The myocardial injury, that is what is defined as the increase in troponin more than 99%. That is what is defined as myocardial injury. So what are the reasons for myocardial injury? Myocardial infarction is one reason, the type 1 and the type 2. Type 1 myocardial infarction is a usual form of myocardial infarction associated with plaque rupture or plaque erosion. Type 2 MI is the more common in COVID-19, the supply-demand mismatch type of heart failure. Myocarditis is another reason, and Takotsubo cardiomyopathy, stress cardiomyopathy is another reason. Pulmonary embolism leading to right heart failure can also lead on to myocardial injury. So all this can lead on to either heart failure or can lead on to arrhythmias. What is the incidence of myocardial injury? It varies from 7% to 20%. And the high-risk patients are identified by the levels of NT-proBNP and also a serial rise of troponin. Serial rise of troponin indicates a high-risk patient. Coming to myocarditis, around 5% of the patients in a large cohort of around 700,000 patients developed myocarditis. And we know that Takotsubo cardiomyopathy, stress cardiomyopathy is a condition where that is one reason in COVID-19 to develop myocardial problems, and it is most commonly affects females more than 65 years. The next question is, can vaccines can lead to myocarditis? Yes, there is a chance. And the mRNA vaccines, the study from US showed that there is 12.6 cases per million doses of vaccine administered. Usually occurs in 2 to 3 days after the second dose of vaccine, but all of the patients who had myocarditis recovered. So whether you will wonder whether we should take vaccine or take the risk of myocarditis. Definitely you should take the vaccine. The risk of myocarditis is very low and the protection offered by the vaccine is much, much higher. And males are more commonly affected with myocarditis, that also you should know, compared to females. What happens to these patients post-COVID-19 who developed the cardiac problem? Most of them, because all of them recover, and at 6 months, most of them have a normal echo with some diastolic function abnormalities. So there is something called long COVID, who are having persistent symptoms more than 12 weeks. So they have a higher, 3 times higher chance of developing heart failure, myocardial infarction, stroke, and arrhythmia. So we have to be closely following these patients who continues to have symptoms. So how to return to physical activity and sports? That is a common question asked. So after COVID-19, to take a rest for a minimum of 10 days, graded resumption of activity and exercise. Exercise restriction is reasonable when you have persistent symptoms and has a history of cardiac involvement. So if there is a myocarditis, a period of 3 to 6 months of restriction from competitive sports is recommended, and you should do a Holter, ECG, and echo. All are normal, then you can resume activities slowly. So to conclude my presentation, heart failure in COVID-19, it occurs in around 7 to 20% of the patients. Mortality is high in patients, those who have this myocarditis and heart failure. And vaccine-induced myocarditis is rare, but the vaccine benefit is more. So all should go for vaccination. And a long COVID, you should be on the lookout for these complications and closely follow up those patients. Thank you.